And it is an enormous pleasure and privilege for me to introduce my close friend, Professor Stephen Bender. Steve is hugely considered by consensus one of, if not the best teacher we have in the field of orofacial pain, diplomate of the American Board of Orofacial Pain, fellow both of the AAOP and the American Headache Society, past president of the American Academy of Facial Pain, member of the Bruxism consensus meeting, and I think that he actually doesn't need for any real presentation. In line with our association's goal to spread knowledge on the basic contents of our discipline, today's topic will be the basic conservative management of temporomandibular disorders. So, thanks everybody. Also on behalf of the board member Zaha Khalife and Ovidio Sarkutu, who are joining us today for this meeting. Steve, the virtual podium is yours. Thanks for accepting this invitation, but actually you are a founder member of the IAOFP, so it's part of the game.
It's part of the deal. Well, thank you so much, Daniele. It's very kind, and thank you everybody for joining us. We certainly appreciate it. We appreciate the support of this organization going forward. It's a truly collaborative effort that we want to put out there so that we disseminate more knowledge of orofacial pain. So I don't want to take up too much time with my intro babble. What I will say is if you are a somewhat experienced clinician, I'm hopeful that this information will be a review and maybe solidify what you are doing. If you are a new clinician, my hope is that it will generate some thought processes of how we go about, as experts, treating people with temporomandibular disorders. Now, I use that term, and I will use that term within the talk. It's not a good term, and hopefully we'll be able to change the terminology at some point, but we call TMDs, or temporomandibular disorders, as a group of disorders that would include muscle, ligaments, joints, and things of that. So with that said, I don't have any disclosures to speak of. If we talk about pharmacotherapy or medications, a lot of it will be off-label use. So just keep that in mind. So there are some learning objectives that I would like to outline. We want to identify some goals and indications for conservative management of temporomandibular disorders. We want to describe the most evidence-based conservative therapies for these disorders, and then how can we, through a case-based approach that I'll try to outline, simple case, how can we develop a stepwise plan for treating these disorders, that's modified just for that patient. So again, we will start with the patient, and I think I did put in my disclosures this picture that you see of this individual is AI generated. So it's not a real patient that we need to be concerned with disclosing their identity. So Elaine's a 42-year-old female. Chief complaint, we always want to know in their own words. Why did they come to see us? I have them write it down, and then when they get to the clinic, I have them tell it to me verbally. It's always good to go over the written information that they give you with the patient and just ask them to clarify, ask them to say it in their own words while they're in the clinic, because sometimes when they are filling out these forms, they're not real clear on how to talk about what's going on. So we go over it several times to try to clarify both for the patient, but also for me as a practitioner. The onset was gradual, approximately 6 months ago. And again, this is all important information to tell us how to approach this patient. No precipitating event. There was no trauma. There was no accident. There was no, chewing hard foods and with a sudden onset. It does seem to be getting worse over time. She describes it as dull and achy, and I emphasize those words because, again, words matter. What they tell us matters. In other words, if they would have said it's burning, that's electrical, we would have switched to a different gear of thinking maybe this is neuropathic pain. But dull and achy describes musculoskeletal pain pretty well. We want to know the location. So we have in our intro forms, we have them circle it. We have them in the clinic point to it. We want to be sure that we know where they're experiencing pain. And so our patient Elaine says it's in the right TMJ region or the joint region itself, with occasional radiation to the temple and the ear. And again, no history of trauma or no systemic entities or things like that that could seem to contribute. So what makes it worse? What makes it better? Well, things that make it worse: chewing, yawning, singing. So again, if she's using the joint, it's kind of like if somebody had a knee problem. What makes it worse? Well, standing up, walking, things like that. Things that make it better: not moving her jaw and massage. And then associated features, she experiences popping of her jaw with occasional locking. She does have increased stress due to how this disorder or this pain and dysfunction is interfering with her normal daily activities and sleep. Past medical history. So, is there anything in her past medical history that can contribute? Well, she does have episodic tension type headache for years, but she hasn't sought specific consultation for that. She takes over the counter medications, and they do seem to help. We want to know about their social history. She does have a stressful work environment. She works in healthcare. She is aware of clenching her teeth in the waking hours. People have told her, and she is aware of it. No tobacco, no alcohol. She's married with 2 teenage children. Why is this important? Because as we've progressed in the field, we know that the psychosocial or the things about this person's life do have a significant contributing factor to making some people less tolerant of the stresses and strains on their joints than others. So people with a lot of social issues like stress and things like that tend to be more prone to having these disorders. So in our physical examination, we note, and again, I'm kind of rushing through this a little bit. Hopefully it's a review for some, but if you're new to this, I want you to explore this better. How do we do exam? So we're going to kind of rush through this just due to the interest of time this morning or this afternoon, wherever you are. So we note tenderness to palpation of the right masseter and temporalis muscles, and she expresses that it's a 4 out of 10. In other words, 0 being no pain, 10 being the worst pain she can imagine. And it's familiar. So we ask when we're palpating, is this the same pain that brought you in? Is this the same pain that you've had for the last 30 days or so that brought you in to see us? And if they say yes, that's familiar pain. So we've pretty much made a diagnosis based on them telling us that this is familiar to them. This is what brought them in. We note on palpating the joints that there is a click or a pop. And crepitus. Crepitus is that crunchy noise that you might feel or hear inside of a jaw joint. And this is both on the right and left sides. No pain with palpation of the joints, though, specifically. And when she opens, her mandible will deviate 3 millimeters to the right on opening and protrusive movements. So let's look at an image, and this is a good screening image, a panoramic film. It's low cost, it's low radiation, and so we use it for our screening because we can get a big wide view. Is there any pathology? What do the joints look like? Knowing that it's going to be somewhat distorted because the X-ray beam goes from, it's a transpharyngeal, so it goes from down here to up here. So we see that there's no significant pathology. The joints themselves look a little altered, but otherwise fairly normal. What we can't discern from these images is joint space, disc position, things of that nature, because in these images, people are biting forward. In other words, when you position a patient in a panoramic image, you have them bring their mandible forward to bite on the little bite stick. Okay, so what's our differential diagnosis? Well, we'll call it myalgia or muscle pain, for a lack of a better term at this point. We'll call it at the right master and temporalis. And then we'll also say that there's right and left degenerative joint disease. Why do we say that? Because we heard the crunchy sound. And according to the diagnostic criteria for temporomandibular disorders, or the DCTMD, that would be considered degenerative joint disease. Okay, so let's move on from our patient, and we'll just look at some broad strokes of temporomandibular disorders in general. Most of the time, they're going to be self-limiting. They're going to remit on their own, or they're going to fluctuate up and down over time. Progression to something chronic and disabling is very uncommon. This is important information to keep in mind when we're trying to decide what kind of treatment we're going to advise for these patients. In other words, if we know that most people get better over time, even if we do nothing, that tells us that we need to do as little as possible, and we'll kind of outline that. Most patients with these disorders do achieve good symptom relief with very conservative therapy, and there's a number of papers that you can refer to that will talk about this. So what is the management protocols? Well, the goals obviously is going to be to alleviate pain. Every patient that comes to see you with pain wants that pain to go away. They also want to be able to eat what they want to, talk, sing, things like that. So we alleviate pain, we restore function. Those are the two most important. To do that, we need to identify what's going on. So any contributing factors, when we know sleep is super, super important, people with poor sleep tend to become more susceptible to these disorders. We know that diet, nutrition, hydration, things like that are important, and then stress. And we talked a little bit about that just a second ago. So how do we approach these patients? Well, we want to give them a well-defined management program. In other words, people want to know you as a practitioner have a plan. Instead of, we'll just try this, they want to know, okay, this is what you have. This is how we're going to treat it. If this doesn't work, we'll move to this and this and this. And then we want the patient to understand what we're talking about and agree to it. And that's important too. Any dentist knows that if a patient isn't fully on board, we shouldn't do whatever the treatment is that we're proposing. And we cannot ignore the emotional psychological factors. And I expressed this a little bit earlier, that we know that those are very, very important for the success of our treatment. If we ignore those, we're going to fall short. Do we become psychologists? No, but we need to know when to refer, or when we can give them tools ourselves to help with some of those factors. So with the progress, the first thing, or the process, the first thing we need to do is educate our patients. I said earlier, patients want to know that you have a plan. They also want to know, what's wrong with me? Everybody says it's in my head. Tell me what is wrong, what is going on. This case is pretty straightforward, but there's other cases that may not be, that patients have gone from provider to provider to provider and not gotten an answer. If we can give them answers, if we can give them hope, we have done everything for this patient without really doing anything with our hands. They will leave our office with a smile on their face, knowing, hey, somebody finally listened, somebody finally knows what's going on, and somebody has a plan to help me. So in that process, we want to try to limit function if that's appropriate. In other words, I don't get carried away with no-chew diets or whatever. It's mostly, if this hurts, don't do that. If that hurts, don't eat that. cut up your food in small bites, limit, your singing, your talking. And we want to control non-functional tooth contact. And there's a number of ways to do that. What does that mean? If they're not chewing, swallowing, or speaking, their teeth should not be contacting. So we do this to decrease adverse loading. And this is not only for sleep. This is for awake time as well. We know that now that awake time tooth contact can increase muscle activity and maybe even be more detrimental than what we do during sleep. And then appropriate pharmacotherapy. Basically, for musculoskeletal disorders, we will use analgesics or anti-inflammatories, and then so-called muscle relaxants. Physical or physiotherapy may be appropriate for some of our patients. And then in some cases, we may incorporate some type of a device to be worn. And in my bias, that would be only during sleep. And I just wrote stabilization orthotic. There's a lot of different names for them, but something to help us in a set period of time manage what's happening during sleep. So again, we start with patient education, and this again is the most important thing we can do. It's called cognitive reassurance, and this is mostly where we take the time to explain in language that they can understand what our clinical findings are, what all the tests we did, what does that mean, what are all treatment options, and this again is important for any type of dentistry or medical practice. We want to give all the treatment options, even if we don't do those in our clinical setting. Patients deserve to know what's available to them. We want to set realistic goals. We don't want to say, everybody that I treat or make this, this splint for, this bender splint, if you will, gets better 100% of the time. That's not true. That's not realistic. And so we talk about realistic goals and then a realistic prognosis. And again, most of these people do very well with very conservative care to a point where it just does not interfere with their life anymore. So basically what we're giving them is the what, why, and how. And there have been studies that have shown just this, the cognitive reassurance is going to improve their adherence to what we are suggesting to them. And also they're, again, going to leave feeling more comfortable and confident, which is going to predispose them to getting better. So we talk about habit modifications, especially if we discern that there is a habit of inappropriate tooth contact during the day. In other words, they're not functioning, but they're bracing their teeth together. So we want them to, first of all, become aware of it, because a lot of patients will deny this. So this is the what. We ask them about tooth contact, but also tongue position, and you may be surprised what the tongue position should be. We want them to know why it's important to change. In other words, this adverse loading is contributing to the pain and dysfunction that you're having, and this is why we need to stop it. We need to explain how this affects pain and how we then break this habit, if you will. So the how is, how do we change the habit? Well, we want the teeth slightly apart. During waking hours, we want the tongue relaxed at the floor of the mouth. And again, there's data that tells us positioning the tongue at the floor of the mouth not only decreases muscle tone, but also decreases sympathetic tone. There's really no data to support the tongue being at the roof of the mouth, but there is data and positioning for these pain patients at the floor of the mouth. We want the face relaxed, and so how do we do that? I personally like to instruct the patient that periodically during the day, using a timer or some other kind of app device to alert them to become aware, and then just to blow a couple puffs of air. And I learned this from Professor Okeson, that at first I thought that sounds crazy, but I tried it myself, and then I had my patients try it, and they actually came back very encouraged. They found that, number one, we made them aware of their habit. Number two, they were able to do this easily, and they feel like it was helping without doing anything else. So we just say, just blow a couple puffs of air, close the lips, and the teeth will be separated. Start out with maybe 30 minutes, every 30 minutes, and then gradually increase your time and do this for approximately 30 days or so. So again, there's a number of ways to do this. There's some apps that you can use. You can just, have a patient use a smart device, their smartphone, to time themselves, just whatever they're most comfortable doing, whatever you're most comfortable prescribing. Some will, I always get asked, well, what about heat, ice, from patients, but also from doctors that we talk to. And there's some basic principles. Ice should be used within the first 24 hours. It does provide some local analgesia. It does reduce inflammation. But if the patient has had a radiation therapy or open wounds or areas of poor circulation, they should not use ice. We need to know that the ice should be used for no more than about 10 minutes, because after about 8 minutes, we start getting vasodilatation, which is kind of the opposite of what we want to try to achieve there. Heat will be used after that period of acute injury, after about 72 hours or so, because that's going to help perfuse the area with more blood flow. We also know that heat will stimulate muscle relaxation in those areas, and so it can be used along with physio or physical therapy. And then pharmacotherapy, there's some basic principles that we need to understand. We can, in some cases, use them as standalone therapy. In other words, some people may just need a short course of an anti-inflammatory, but other times it's used as an adjunct along with other treatments. I am not, or never have been, a big prescriber, especially for these disorders. Now, things like neuropathic pain, then that's more essential to prescribe pharmacotherapy than these. So typically it's an adjunct to get the patient from a point where the pain is interfering with their function to where they can tolerate it. It's no longer interfering with their life. So a short course of pharmacotherapy can be helpful and important in these types of individuals. I do not believe for these disorders that opioids are appropriate. I haven't prescribed an opioid in, probably since I began my orofacial pain career, which is about 26 years ago. Now, there are some that feel differently than I do, and that's fine. And we need to use the normal cautions that we use if you are going to use opioids. But we know opioids are what we call pro-nociceptive. In other words, even after single doses, it can change the physiology to alter our pain thresholds. And this is not tolerance or opioid-induced hyperalgesia. This is something different. It actually changes our physiology even after a dose or two. So try to avoid them as much as possible. Again, I feel that they're not appropriate. So again, we have analgesics and muscle relaxers basically in our armamentarium for these disorders, and we'll look at those just a little bit. As far as analgesics, we consider NSAIDs to be the primary medication that we used. How do we determine which one? Because they're not all the same. It's going to be based on their cardiovascular profile as well as their gastrointestinal profile. We also need to understand that one size does not fit all. In other words, some people say, well, I can't, ibuprofen never works, so I'm not going to take one of those. Can we try something else? Well, just know that maybe another one, like naproxen or diclofenac or meloxicam, one of the others may be helpful where ibuprofen was not. So it's worth a trial. Corticosteroids can be used. I always use them just for a short burst or a short tapering dose in significant joint-specific pain. You can use that as an oral dose, or you can use it as an intra-articular injection, a very, very small amount I would recommend. Salicylates are often forgotten, but in some cases they can be appropriate for certain patients. Acetaminophen or paracetamol can be used. and paracetamol or acetaminophen, often in combination with an NSAID, can be more effective than either one by themselves. And then we talk about the atypicals, and those can be the tricyclic antidepressants, namely nortriptyline, amitriptyline, the gabapentinoids or gabapentin, pregabalin, maybe in some cases CBD if it's legal in those particular areas. And then there's others that can be used if all the primary sources are not appropriate or do not work. And then a lot of times in pain management, pharmacotherapy is like mixing a recipe. So we kind of think in our brains, what's the mechanism of pain here, and what could best be used? And sometimes it's combinations of different agents that work more effectively. So just briefly looking at NSAIDs, again, there's a number of them. I just listed the most commonly used, and we talk about, again, the gastrointestinal, cardiovascular. So we know ibuprofen, as far as the non-selective NSAIDs, is going to have the lowest GI risks. And so if somebody has gastrointestinal concerns and we can't use a more selective like celecoxib, then we might use ibuprofen. Naproxen has a more favorable cardiovascular risk. Naproxen sodium is going to have a faster onset, and so somebody with more acute pain that needs a faster onset, this is going to maybe be 30 to 45 minutes, whereas the others are about an hour. Diclofenac has a very unfavorable cardiovascular profile. It does have a good GI profile, but if your patient has any kind of cardiovascular concern, diclofenac, and that includes topical, is not appropriate. Meloxicam has a good GI profile, has a slow onset of action, which means it takes a while for one dose, but also it takes multiple doses before patients start noticing a positive effect. And so you need to warn your patient that you're not going to feel something right away. This is going to take a day or two before you start noticing, so don't give up on it. And then celecoxib, at least in the United States, is the only purely selective. In other words, it doesn't affect the gut mucosa, the protective barrier, so it's got a very good GI profile. Really not much data on muscle pain. It does have significant or more significant data on joint pain, specifically, especially in arthritides. Okay, let's move to corticosteroids, just again, very briefly. And as I said, I mostly recommend these to be in the moderate to severe joint specific pain. Now, they do obviously have anti-inflammatory effects, but they also have analgesic effects, probably blocking C fiber transmission. So, we get a little bit of both there. Not really well studied on muscle pain, although they can be used. There is some data for using very small amounts in trigger point or painful muscle injections. And again, I would use a very, very small amount because it can be myotoxic, and I would use the more aqueous, like dexamethasone, as opposed to something more particulate and thicker, basically. So the muscle relaxants aren't really muscle relaxants. And what do I mean by that? I mean, experimentally, they seem to reduce the neural activity that causes muscle contraction, but the experimental animal doses we can't tolerate as humans. And so we're taking a much lower dose than what was used experimentally. So what do they do? Because we know they do help some people. Well, they seem to have some analgesic properties, but also sedative properties. And so that's why we tend to prescribe them mostly at bedtime, at least to start with. And so we start with the dose at bedtime. It's going to help them sleep, which is going to be healing, and it also does have some analgesic properties. That's how we suspect that they work at this point. There's a couple different classifications, and these can be classified different ways. I chose to say antispastics and then the skeletal muscle relaxants. Within those categories, We have the antispastics, we have the benzodiazepines, we have the medication called tizanidine, baclofen, and then botulinum toxin would fit into that as well. And then the skeletal muscle relaxants, we have cyclobenzaprine, which is probably the most utilized within the orofacial pain world for temporomandibular disorders or musculoskeletal pain. Carisoprodol, which is an older skeletal muscle relaxant that I would recommend you don't use. It's a prodrug that breaks down into what is known as meprobamate, which is a very potent anxiolytic that people like the way they feel. And so they take it, they want to keep feeling that sensation. And so it becomes more habitual for them. So there are some downsides to that. So I always tell students, just don't even start a patient on that. It's one of the two medications that people will ask for. Patients will ask for that and hydrocodone. Metaxalone is another skeletal muscle relaxant. It's thought to be the non-sedating muscle relaxant, although in some individuals, including myself, it does cause sedation. And then methylcarbamol is an older but still effective. We can use local anesthetics. And again, if we can find a very specific tender point or painful point, we can use a local anesthetic. I would advise it to be something like lidocaine or even bupivacaine in some cases, but without a vasoconstrictor because it can be myotoxic as well. This is I was taught that you shouldn't inject a muscle unless the patient is undergoing physiotherapy or physical therapy, whether you prescribe it or they go to a professional. So it should be an adjunct so that you inject the area and then you have them immediately or near immediately do some kind of stretching or physiotherapy for that particular muscle. There is, again, some data that suggests corticosteroids mixed with that is maybe more effective, but I would use a very, very small amount for that. And then oral orthotics, some people use the word splint. I don't like that term. My friend Gary Classer kind of got me thinking about that term. We're not really splinting anything together. And so I like to use the term orthotic, or there's a lot of other terms, and you can do whatever you're comfortable with. But I like to use this term. Do they work? How do they work? Those are good questions. There's a lot of thoughts on how they work, but we really have no data specifically on what they are doing. There's a couple different thoughts that seem to make the most sense to me. Maybe it's biomechanical. In other words, we are changing the vertical opening, which is going to change recruitment patterns of some of the muscles, which will change force vectors and loading. That's a possibility. It's also, maybe we are again opening the bite, and there's some older work from Dorit Nitzan. She did many years ago that showed a decrease in intra-articular pressure. It's possible that that decrease in the intra-articular pressure provides some atmosphere for healing. So these are some possibilities on why these things work. But we need to understand they don't stop sleep bruxism. So if we're making them, we can't tell our patient, because a lot of patients have heard this, that this will stop your grinding at night. It doesn't. The activity still occurs, but by mechanisms we don't understand, it does allow a period of time for healing. My bias, and at this point in my career, I'm not afraid to give my bias. I feel like these should be used for sleep time only. I'm not a proponent of putting something in a person's mouth during waking hours because I feel like they will close on it. And some would suggest, well, they are breaking the habit then. It helps them break the habit. I gave to you my way of helping to break the habit that doesn't involve resting the teeth together on something that will trigger muscle activity. So again, my bias that I feel very strongly about, I don't want them having something during the day. The only time I've ever done that in my career is when people had movement disorders. And so we put in a device that would give them something to rest on, because we know that putting something in the between the teeth with certain movement disorders will temporarily block that movement. It's a distraction technique. So again, do we have any evidence? And we don't have good evidence. So this is a few years old, a systematic review. They had a fair number of randomized controlled trials, and basically they came to the conclusion that there's a very low certainty evidence that really demonstrate that these devices reduce pain. So the evidence is not good, and some of the limitations of these studies are: number one, the diagnoses were heterogeneous. In other words, all these patients weren't they didn't phenotype them specifically to a certain disorder. The device type used was variable, and so it wasn't a consistent device. And their outcome measurements, in other words, what pain scale did they use, range of motion, quality of life, things like that, weren't consistent. So the studies basically at this point aren't good. And so that tells us we don't have good evidence. That doesn't mean they don't help people. That doesn't mean I'm saying don't use them, because I use them very frequently in our patient population when I felt it was appropriate. And they did seem to help. Was it my fantastic design? Probably not. It was probably a lot of placebo that I incorporate into my practice. And that's a whole another lecture in and of itself that at some point maybe we can talk about. So there are different types of devices. I'll talk about a few of them. Anterior repositioning or mandibular advancement, anterior contact only, the soft or resilient types, and then what we call stabilization orthotics. So anterior repositioning is basically a device that holds a lower jaw or mandible forward in relationship to the maxilla. These are sometimes used in acute joint injury or for disc recapture, but disc recapture, I will tell you, is not a reality. In other words, once those ligaments lose once they are elongated, they don't have stretch properties, so they won't go back. And so once they've elongated and the disc is out of place, it's going to stay out of place. You can't capture it and move back. These are really no better than the so-called stabilization devices for reducing joint noises. So the basic rationale or hypothesis is hypothetical and not really supported by evidence, and they can lead to occlusal changes. If we keep the mandible forward for prolonged periods of time, we will see changes, and so if we can avoid that, we should. And these are a couple examples you can see in the top left. You bite down, and it's a maxillary device. You bite down, brings the lower jaw forward. And then the lower one is more like a sleep apnea device that holds the lower jaw forward at all times. Now, the anterior contact, you're probably very familiar with this type of device that fits on, usually it's the lower dentition where only the anterior teeth will touch it throughout all the movements, trying to keep the posterior teeth separated. Why? Well, we know that the periodontal ligament has a very rich network of mechanoreceptors. And so these mechanoreceptors identify load that tells us to do something. In some cases, this is for the muscles to brace. We know that the density of these fibers increases the more anterior in the arch. So again, the anterior teeth are going to have much more extensive density of these mechanoreceptors, making them basically more sensitive to bite down on. Have there been studies? Well, there have been a few. And again, it's been several years, but there was a short-term study, 2 weeks, that indicated a strong inhibitory effect on EMG activity in these muscles, and this was during sleep, this particular device. Again, very short-term, very few patients, only 10 patients, and the decrease in EMG activity really didn't correlate to a clinical outcome. In other words, yes, the muscle activity for this period of 2 weeks was reduced, but did they clinically get better? Not necessarily. So again, 2 weeks is a very short period of time. People can adapt to these devices potentially, but it also, expecting a significant positive outcome in 2 weeks is not realistic either. So, how about the soft or resilient devices? I call them chew toy devices for a lot of different reasons. I believe that they tend to make most people better or most people worse. And yes, there is very little evidence to support them. And then some older studies by Professor Okeson saying that in half of the individuals, the sleep muscle activity does increase. So I have not been a big proponent of these unless somebody needed an emergency device. And they can help. Just about anything can help for a short period of time. And then the so-called stabilization orthotic, flat plane splint, occlusal orthotic, centric relation splint, Michigan splint, and so on. A lot of different terms. These were first described by some well-known occlusal experts, Ramford and Ash, back in the 50s. Usually they're going to be made of a hard acrylic type material or some other printed material now. They tend to be full coverage on the upper or lower arch. People will say, well, which one do I use? Which one is best for an individual? Well, there's no data to tell us one is better than the other. And what I always told students, let's say a person, you made one on the upper arch and it wasn't helping, or the patient couldn't tolerate it, well, then make one on the lower arch, and vice versa. We do know that maxillary appliances in a couple studies have shown to increase the severity in probably half of the subjects that have obstructive sleep apnea. And so if somebody has a hint of sleep disorder breathing, or you suspect it, you may consider just making a mandibular or lower device. So in the prescribed making of these devices, it should provide a stable physiologic mandibular posture. In other words, just a normal relaxed bite for these individuals that's stable. And then even occlusal contacts for the opposing arch on the device itself. What is known as anterior guidance or discluding the posterior teeth can be accomplished by just putting some kind of ramp in the anterior that will let the canines or other anterior teeth disclude the posterior teeth during these excursive movements. So this is what they will look like. You can see the even dots on the one on the upper left with the lines for the guidance, if you will. If in doubt, also you can just cover up the most uneven arch to make things as even and physiologic as possible. Now we'll look at a couple others. There's the devices that only let the posterior teeth touch. So this is going to be bilateral hard acrylic platforms on just the posterior teeth that's thought to distract. In other words, you have the load in the posterior teeth. It's thought to distract or unload the joints. Sometimes they are made to produce what's called a ideal condylar position, whatever that might be. And then what we know is that these can, if not used as prescribed, or even in some cases, they can produce occlusal changes or changes in the arch, which is then going to require more work. So this could be restorative, could be orthodontic, could be orthodontic. And there's really no evidence to support their use. The distraction is just kind of a myth. So here's what they look like. You can see the upper left, you can see the posterior teeth are covered with a plastic and there's nothing in the anterior teeth. And this is the results in the lower right. There's what's called a pivot appliance, and it's based on the same premise as the previous one. In other words, if we put this material on one side, we can unload it. We can distract that particular side by increasing the load on the opposite side. So it's thought that we can reduce the intra-articular pressure by this mechanism, but again, there's really no evidence to support this. And actually, it may even increase the compression in the joint that you're trying to unload. So here's an example of what that looks like. And no, I didn't make that. There's the hydrostatic devices, and you've probably seen these marketed as something that's quick and can provide immediate relief for some of the patients because it's kind of a one size fits all over the counter. So it's bilateral fluid filled chambers. It's thought to allow the jaw to settle into that so-called ideal position. There is no independent research to prove these claims. There are a number of patients that I have seen over the years that used them and felt like they did help in the short term. When they first came out, they were sent to me to try, and they wanted my feedback, and I couldn't wear them. I found them to be extremely uncomfortable, and I ended up popping the little chambers, and I gave them my feedback and never heard from them again. Lastly, there's what we call the anatomical or directional, and these are going to be devices that build an ideal occlusion and try to produce the ideal condylar position. These are usually based on EMG readings that the practitioner will do prior to treatment to find the most relaxed position, and then they build an occlusion with the thought that when this helps, then they will go to phase 2 and recreate that ideal position permanently. So that's two-phase therapy. They tend to look like this. In other words, they look like teeth. They have increased vertical dimension. And again, there's really no good data to support their use, and it does necessitate having multiple restorations and or orthodontics, orthognathics, things like that. And I will take you back to our first few slides that talked about how most patients will get better with very little to very conservative therapy or no therapy at all. And so that tells you, at least in my tiny little brain, we don't need to do this. We shouldn't do this. We should try to let the evidence guide our treatment and do very conservative therapy. Now, there are sometimes talks of doing occlusal treatments, in other words, changing the bite relationship. And this can be adding to the teeth. This can be grinding away. This can be with orthodontic or moving the teeth. It can be orthognathic, where we use surgery with orthodontics, or it can be a combination of all the above. So what does the data tell us? Well, there's really no difference in the treatment between those that underwent a mock equilibration and those that actually had their teeth adjusted. So a mock equilibration would mean we aren't adjusting the teeth. So no difference there. Mock equilibration alone is enough to cause the relief of symptoms in over half the patients. Placebo works over 50% of the time. Now, that doesn't mean we do fake therapy on our patients. That means we use tools like appropriate speech, like appropriate touch, maybe a hand on the shoulder or something, that assurance that we care. In other words, I'm going to be with you every step of the way through this process. Here's my plan. I'm not giving up. If we just express that, then our treatments are more prone to work. And then we know that also from this was a Cochrane review that randomized controlled trials that occlusal adjustment does not treat or prevent TMDs. So there's no evidence to support that. And then orthodontics, another Cochrane review, there's no evidence that orthodontic treatment can prevent or treat temporomandibular disorders. And where are students and young practitioners always told to send these patients? Orthodontist, oral surgeon, prosthodontist. So they're all bite-related issues. And so I always try to tell our students, these are not the three you should start with. Either get comfortable treating them yourself, or refer to an orofacial pain specialist in your area or somebody with advanced training in evidence-based therapy. Orthodontics, and this is Professor Manfredini's, some of his earlier work, is basically TMD neutral. In other words, again, it doesn't help or prevent temporomandibular disorders. So this shouldn't be our first choice of therapy. And in fact, orthodontic treatment can destabilize the system. And this is early work by Professor Chuck Green. What does that mean? That means these patients, as I said earlier, are probably more sensitive to change. So a number of patients will present to your practice at some point. They did mine where they were in the middle of orthodontics or near the end of orthodontics and started having jaw pain, jaw popping, things like that. And they wanted to blame the orthodontics. And I would always tell them, it's not that. In fact, your bite relationship is beautiful. The orthodontics is beautiful. Your teeth look great. Some people just can't tolerate change the way others can. And so they are more susceptible. They are less adaptive. So you need to know who those people are. So I'd always tell students, this is why you need to know who you're treating. Get as much information as you can because you may start to do all this beautiful restorative work and they start having pain. Why? They're less adaptive. And so get to know your patient. So other therapy considerations might be clinical psychology from a trained clinical psychologist in pain management, and there's really good data for that. Clinical hypnotherapy, not good data, but it could be beneficial for some mindfulness exercises. Acupuncture, data's not real good, but there's a lot of people, the data's getting better. And again, standardization is helping that. And then low level laser or photobiomodulation, again, is getting more data to suggest that it can be helpful as well. So let's get back to our patient Elaine. So our differential diagnosis was myalgia or muscle pain on the right side, and then degenerative joint disease. So our treatment plan, again, based on what we know, is going to be always patient education, limit function as much as possible, and then control our non-functional teeth contact. And so that's awake and asleep. During waking hours, behavior modification, and that's the repetitive reminder to keep our teeth apart, relax the jaw, relax our face. And then during sleep, we may use an oral orthotic if it's appropriate. A lot of people, believe it or not, will do very well with just daytime behavior modification. So we also want to limit chewy foods maybe for a period of time, use the timer again for behavior modification. We always talked also with our patients about breathing and posture. We know that proper breathing with the diaphragm, in other words, feeling the stomach move with our hand, will lower sympathetic tone. And pain patients, by and large, will have increased sympathetic tone. So if we can lower that tongue posture, body posture, breathing, we can help these people get better. And then mindfulness, especially for Elaine here, for stress management. In other words, I say just take a little breaks during the day to just breathe, posture, and then if you pray, say a prayer. If you like to just look at nature, do that. Something to just escape and bring down the sympathetic tone. Take a walk, anything that you can do during the day. And then diet and hydration we know is super important as well. We may incorporate pharmacotherapy for this patient, maybe a short dose of NSAIDs, maybe a muscle relaxer at bedtime short term to help with sleep and analgesic. You know, in some cases, we could consider botulinum toxin if the patient is refractory or other treatments are contraindicated, but it's not a first-line therapy. It should not be. Why? It doesn't always work, and it's expensive. And then we may consider something to use an oral orthotic, custom fitted for sleep. We may incorporate physical therapy, and this would be early in the process before we got to botulinum toxin and things like that, and maybe even before we gave them a sleep device, at least in my bias, to do some different techniques, myofascial release, stretching, ultrasound, moist heat, people in a well-trained physiotherapist, people do really well to these therapies. So we do recommend that these patients are followed up, and an amazing amount of patients were given devices to wear during sleep before they saw me. And I said, was there any follow-up, any adjustments? No, they just said, here, take this, and let us know, if it's helping. So I would give them very structured follow-ups. In other words, about 3 to 4 weeks, I want you to come back. We're going to monitor your symptoms. You're going to tell me how you're doing, basically. Any problems if they're wearing, especially if they're wearing a device. With the device, do we need to adjust it? And then we reinforce the behavior modification of keeping the teeth apart, watching what they eat, things of that nature. So finally, just looking again from a drone's eye view, if these patients are very acute, in other words, less than 3 to 6 months or in that time range, just consider the self-care. Just, here's some self-care, keep your teeth apart, breathe, do all these mindfulness things that we know can help lower sympathetic tone, maybe some over-the-counter medications. And this can be very successful. And some people say, well, that's not really good practice building. I promise you, if you treat these patients very well and very conservatively, they're going to tell other people how that was helpful and they didn't have to spend a lot of money. And so it does become, financially feasible to do these kind of therapies, to do the right thing. And then if they're chronic, then we want to consider more the behavioral factors. Again, the psychosocial, in other words, what's going on in this person's life. And our jobs as clinicians, even though we're dentists and we say, I don't want to hear about your psycho or your social, as pain clinicians, we need to know these things. And so you need to get comfortable asking. And these uncomfortable situations become more comfortable over time the more you do them. So that's our job as pain clinicians, is to delve into some of these factors within reason that may be contributing. So you may consider some kind of oral device, physical therapy, and other health factors. So just to kind of sum up, we know that TMDs, for lack of a better term, are common in the general population, especially in the female population, and it seems to be around the childbearing ages. And this is true in headache medicine as well. So we know that hormonal factors are a big influence. Most of the time they're muscle, and I put in parentheses, perhaps tendon. And I would refer you to a recent paper by Professor Manfredini and his son, Giacomo, along with some others that was just published, that talks about why tendons may be more important than muscle. They can be acute or chronic, so we know that. We know how to approach each. The etiology involves more than the mechanical. It's not the bite, it's not the jaw position, although changing the bite can lead some of these non-adapters into a clinical presentation. So we don't want to ignore the psychosocial. We want to keep that always in mind, that these patients may have something happening there. And then finally, most patients are going to do very well with conservative care. So avoid invasive, irreversible therapies at all costs, because again, we are doing the patient a service, our practices will grow, and we know that we're doing the right thing. And, you start doing these irreversible therapies and you can start messing things up. So thank you again for being here and your attention. If you need anything from me or would like to communicate, my email's right there. So I will stop sharing.
Thank you very much, Steve. Thank you very much, Professor Banner. Wonderful excursus and overview on the fundamentals of conservative management for temporomandibular disorders. And as you said, Steve, I think that it's been very useful both for the beginners, but also for the experienced colleagues to have a sort of wrap up of the current literature and evidence-based information. So thank you very much. Of course, for the colleagues still willing to interact with within the chat, it is not possible. It is something that we have already said multiple times in the previous events. This is not an open orofacial pain master course. Okay, so I tried to answer as much as I could, but we will have other opportunities to interact all together. By the way, this is a special Monday because we have also a lecture